This is week 15, Professional Issues in Prenatal Genetic Counseling. The learning objectives for this week are to discuss personal perspectives on sources of stress and gratification in providing prenatal genetic counseling, to discuss self-care strategies for stress reduction, to discuss the scope of practice of genetic counselors and the roles of diverse healthcare providers in prenatal screening, diagnosis, and counseling, and to review the NSGC Code of Ethics on patient autonomy and decision making. We will begin this section by talking about the NSGC Code of Ethics. The NSGC Code of Ethics is a document that attempts to clarify and guide the conduct of a professional so that the goals and values of the profession are best served. It is based upon the distinct relationships genetic counselors have with themselves, their clients, their colleagues, and society. Please go to this link to review the NSGC Code of Ethics. Today you're going to be seeing that a lot of the other healthcare professions and allied health professions are going to be doing a lot with genetics because they have been including it and increasing the amount of content in their various training programs. Please go to this link for the scope of practice from NSGC for the role of a genetic counselor. And again, this is something that we're going to be studying in much more depth when you get into more of your clinical and into your second year. Today, with the expansion of technology in prenatal diagnosis, we have direct examination of the fetus by utilizing fetoscopy, ultrasound, magnetic resonance imaging, and we have indirect determination of fetal status by amniocentesis, chorionic villus sampling, fetal tissue sampling, and cell-free DNA. Increasingly today, more and more parents who are known to be at risk are turning to pre-implantation genetic diagnosis of embryos that have been created by in vitro fertilization to decide which embryos to implant. And with this increased technology and this explosion of knowledge, the physician's obligation to keep patients fully informed about their reproductive options has increased. In looking over some general concepts of medical malpractice falls under the umbrella of torts. Torts are civil wrongs that occur between private parties. In most cases, almost always actually, the torts are governed by state law and brought under a state law theory of negligence. Fundamental to an action in medical malpractice is a legally recognized relationship between the two parties concerned. In order to establish a case of negligence in a court of law, the plaintiff or healthcare consumer must prove several elements. Number one, that the defendant, healthcare provider, owed a duty to the plaintiff to meet a legally defined, often professional standard of care. Number two, that the duty was breached. And number three, that the breach of duty was the proximate cause of legally cognizable injury to the plaintiff. In order to establish a case of negligence in a court of law, the plaintiff or healthcare consumer must prove several elements. That the defendant healthcare provider owed a duty to the plaintiff to meet a legally defined, often professional standard of care, and that the duty was breached and the breach of duty was the proximate cause of the legally recognizable injury to the plaintiff. The plaintiff may also ask for money damages to be awarded as compensation. There may be general damages for physical and emotional pain and suffering, or there may be special damages for economic losses, including medical expenses, lost wages, and the cost of rearing a child. Sometimes punitive damages may be included if the conduct of the defendant has been grossly negligent. In looking at the constitutional right of privacy in reproductive decisions, in most cases involving children with genetic disorders, they derive from claims that parents were deprived of their right to make their own decisions about conceiving and bearing children. In most cases, it is believed that the healthcare providers were negligent, either in performing sterilization surgery or in providing sufficient, accurate information about reproductive risks. The parents believed that they had the right to decide not to have children. Please remember that statutory prohibition of abortion and even contraception were quite common for much of the United States for a lot of the 20th century. In fact, if you even look in chapter 32 of the text, it talks about in 1965, a Connecticut statute banning the use of contraceptives by married couples was held unconstitutional by the United States Supreme Court. The court found that the statute to be impermissible intrusion by the state into a constitutional right to privacy in the marital bedroom. If you look at that, it's just amazing that this was the year 1965. A critical issue to understand is that in many wrongful birth and life cases, was the physician at fault? Did the physician fail to disclose information that was material or could have been influential in the patient decision-making process? And it's also important to remember that the standard of disclosure that is used to measure a physician's conduct varies throughout the United States. The major claims that have been brought after the birth of a child with a genetic disorder or congenital anomaly are wrongful birth and wrongful life. Wrongful pregnancy or wrongful conception is where the parents claim that they tried to avoid pregnancy altogether, usually by surgical sterilization. In such claims, it often arises where the parents have a normal, healthy child and seek to recover damages from the physician who negligently performed the surgical procedure or whose conduct was negligent. Damages that are sought include pain and suffering of the first sterilization procedure, the unwanted pregnancy and birth, and the loss of service. Some parents may choose to seek special damages to cover the cost of raising a normal child to adulthood. All of this is dependent on the statutory law, the judicial receptivity, the precedent, and the litigation climate in the specific state. And if one reads about the different cases in chapter 22 of your text, you will see that things have changed through the years. Attitudes have changed on what parents should be allowed to have in such cases. In looking at wrongful birth, where the parents claim after having a child with a genetic disorder or congenital anomaly occurs, such cases that would be under this category would be those in which the parents who have had their carrier status misdiagnosed, those in which the parents have had a previous child that was not diagnosed with a genetic disorder. And more commonly, these would occur when parents state that they were under the mistaken impression that their pregnancy was normal, since their physician stated there was no risk. In all cases, the parents must prove that they should be compensated, and this differs by the state. Chapter 32 of Genetic Disorders and the Fetus by Malinsky and Malinsky discusses many of the different cases that have occurred in the United States. And many of them are very interesting to read, and you will be going over a lot of this material when you continue in the second year when we go through various case studies. So I would look them over and I would use them for at a later time when you are doing case studies. In looking at prenatal diagnosis and pre-implantation diagnosis, we see that the laws and the policies on prenatal diagnosis, P&D, are not as numerous nor as restrictive as those on pre-implantation genetic diagnosis, PGD. Why is this? Well, both involve prenatal diagnosis, but P&D is now considered part of routine prenatal care, whereas PGD occurs in situations with in vitro and involves difficult choices, and these include sex determination, deliberate selection in favor of certain disabilities, and the so-called selection of savior siblings, those siblings who carry specific genes that the parents may be looking for in order to save their other children who have a specific disease. I want to close with a brief discussion of self-care in relationship to genetic counselors. Due to the caregiving nature of the profession, many genetic counselors are susceptible to compassion fatigue, defined as feelings of anger, depression, or apathy felt by an individual as a result of being exposed to the trauma or suffering of another. And some of the self-care methods that have been identified by the National Society of Genetic Counselors in a survey that was done to lower the stress and compassion fatigue include working with other genetic counselors and not working alone. Don't just read genetic counseling materials, read literature that's in other fields. Interact with other co-workers, including other genetic counselors, and to set limits with patients and colleagues, and to exercise and diet and have rest and have relationships and play so that you have a more well-rounded person. Um, so think about those as we go into your second year and you start your summer rotation, that genetic counselors, many of them, become susceptible to compassion fatigue.